If I look back now from 2013 and would I still do this again and did we learn from it, it really has become a living, the accreditation documents have really become a roadmap for us. I'd say this is a living process. We've continued to interact with ACE as we've continued to make changes, and I think it remains a roadmap for our future. The changes required to be competitive are going to involve lean processes. Changes in practice, as I reflect on how this impacted us, this is a time in which a lot of things were going on. We got our first NCDR reports of appropriate use in the fall of 2011. Stent rates and interventional rates were dropping around the country. There were a lot of things going on, but I think some of this clearly was the impact of our ACE review. Our DES usage dropped from 1.7 to 1.4 per patient. Our FFR use rose from 40 cases in 2011 to 430 in 2012 and continues to rise. Again, I think cause and effect here is hard. Lots of things were going on in the interventional arena, but this also coincided with some of the reflections we had through our ACE accreditation. In terms of our AUC appropriateness, so the first report in December of 2011, our overall appropriateness was 87%. In September of 2012, close to 94%. The reference point in that in the database was 89%, so we're doing a little bit better. And not classifiable, which is missing data. We were 6.8% in December of 11, 2.8%, and again the reference in the NCDR is now at about 8%. We became very conscious of making sure this data was a part of our charts. It was a recommendation of ACE. I think it's actually become our favorite meeting amongst the interventional cardiologists, where we show cases all blinded and then rate them and for appropriateness. So every interventionalist has cases that are randomly reviewed. Improved documentation, AUC ratings. I think we felt much more comfortable with the idea that we would have the data to avoid RAC audits or paybacks, and we really had improved collaboration at all levels. It prepared us for the future, which we are in. The physician and staff engagement in quality and processes was a very important part of this. Creating efficiency of processes is, I think, remains one of our challenges that we continue to work through. It's all about the documentation. It certainly was the issue for us. And finally, it's ultimately about patient care and quality.